For sure.
I should have brought my candy corn. So I worked with a producer for Channel 4 News in Milwaukee for a while, and she gave me the great advice that when you're on camera and you're worried about cotton mouth, just eat a candy corn. And
That's
I don't know what
point.
it is about it,
I
because
get
it's
the
sweet
same
and
dry mouth
salty.
at times, and it drives me nuts.
Oh, and it sounds horrible on radio and on TV. It sounds horrible. Do I look normal? Am I okay? Do I look like
You
I'm
look
in
great.
a windstorm?
You look good.
Oh,
Yeah, you look good.
yikes.
You got 2 minutes.
All right, we got 2 minutes.
2 minutos.
Don't forget to press your unmute.
Of course. Gotcha. And this has a good battery in it?
I just replaced it.
Okay.
Yeah.
I was gotta check the IFB battery and everything. Production crews are good. That's what I forget.
This is so important. I'm glad we're doing this.
Yeah, me too.
This
Thank
is
you
a
for
good one.
inviting us
Thank
this
you
month,
for
too.
reaching
yeah,
out.
Yeah, yeah.
Awesome.
So good.
We got it done
Inviting
quickly
us.
too.
We did. We have lots of
Get her
these
done.
kinds of things off the shelf that we're happy to share with you. You have other topics. that
I'd
you
love
want?
that, please.
Alzheimer's,
As many as you want to
tissue-based
do,
genomics.
we can do it monthly.
We
If you
have
want to come in and
one for Alzheimer's.
we just did Alzheimer's.
Okay.
We just did Alzheimer's. If
So,
there's
November is Alzheimer's Awareness. If you'd like us to come back.
Let's do it.
We have Dr. Hancock who would love to come and
Let's
speak.
do it.
Okay, perfect.
Yeah, well, let's set it up.
Awesome.
As many as you want to do.
I love it. Thank
But
you.
we gotta get tissue-based genomics in.
Yeah. Sounds good.
It's a good thing. I won't cover that in this lecture. How long do I get?
As much time as you need.
Oh, good.
Yeah, we're not on a time
I like
crunch.
Reasonable. She can talk forever. I should have warned you. This is her passion.
Awesome.
Don't say that.
We have to be gone by here because we have cocktails. Remember?
That's right.
Okay.
Hang on. I'm in.
Well, I'm gonna say go, but the moment that you actually see yourself on the screen, you're live.
Okay. Sounds good.
It takes a little moment once I press the enable screen. All right, I'm pressing it now.
Okay. Hello, Trilogy Network. It's so nice that you joined me today for a great show called Prostate Cancer, No More Poke and Hope. We're going to talk about prostate biopsy today and the history and evolution of prostate biopsy. So you owners out there who have been nice enough to be part of the audience, and those of you even touring a property or sitting in the lobby doing something to pass the time until you see your property, thank you for joining us. My name is Bernadette Greenwood, and I'm Chief Research Officer at HALO Diagnostics, formerly Desert Medical Imaging in Indian Wells, California. I'm also a PhD candidate at Radboud University in Nijmegen in the Netherlands, and I'm on faculty as a clinical instructor at UC Riverside School of Medicine, Department of Internal Medicine. In terms of my disclosures, no one paid me to be here. I'm here because I want to be. I do have one disclosure. I've got a patent pending for a surgical technique that I developed about 11 years ago called laser interstitial thermal therapy. Maybe some other time we can talk about that, but today we are going to talk about the history of biopsy strategies, the evolution of multi-parametric MRI of the prostate, technical aspects of MRI-guided biopsies, the rationale for MR-guided laser focal therapy of prostate cancer, a little update on our clinical trial, and if we have time, I'll talk about tissue-based genomics, a test called Decipher. So a lot of what I learned about prostate cancer is parallel to what I learned about breast cancer. Imaging has a very special role in both diseases, but it seems like breast cancer got all the attention early on, and now prostate cancer is coming up from behind. Prostate MRI is a great adjunct or supplement to the standard of care, which is essentially PSA testing, prostate-specific antigen, digital rectal exam, and transrectal ultrasound-guided systematic biopsy. So my philosophy has long been, if it looks like a skunk and it smells like a skunk, it's probably a skunk. So if I could see it, I could stick it. And if I could stick it, I can not only get good cellular architecture and Gleason score, but I can also figure out what's going on with the genomics in that tumor. So I'm going to go through a little bit of a literature review. I hope I don't bore you, but this is important. You know, history is painful, but we can't forget it, and it's how we got where we are. So in the 20s, the way that they did biopsy was they would do an incision in the man's perineum, which is essentially the crotch. And they would kind of poke around and feel and then take biopsy samples from where they felt something funny. Then in the 30s, Estraldi and his team came up with a technique to feel the back part of the gland with a gloved finger, put a stainless steel sound down the urethra, and then take biopsies with finger or digital guidance. So I imagine there were a lot of needle pokes to the finger back in the day, but that was improved upon when Watanabe-san and his team developed the first clinically useful transrectal ultrasound images. And then at the same time, McNeil et al. Developed the what we know now is the zonal anatomy of the prostate gland. So whether you're a urologist, surgeon, you're a medical oncologist, you're a radiologist, or you're the patient, we're all talking about the same neighborhood using the same language. Then in the 80s, transducers or ultrasound wands, or probes as they're referred to, they evolved to where we could put them in structures like the rectum or the vagina, and we're able to do anatomy of female reproductive organs. We were able to look at the prostate transcavity rather than from the outside of the body. At that same time, the PSA test, which was developed by my good friend Dick Ablin from University of Arizona in 1970, that test was approved by the FDA for screening for prostate cancer. And then right around that time, Hodge et al. Came up with the sextant biopsy schema, where what they would do is go in through the rectum with an ultrasound probe and take out 3 samples from the left and 3 samples from the right. Then Staminescu said, well, if 6 is good, by golly, 24 is better, or 18 or 12 is better. So rather than only taking samples from the red dots, they would take them from the red and the blue, the red and the green, the red, blue, and the green. But you'll notice there's areas that just aren't covered. So then Winston Barzell, a very famous urologist, came up with transperineal mapping biopsy, whereby a plate with holes in it every 3 millimeters is put on the patient's perineum, the space between the scrotum and the anus, and samples are taken every 3 millimeters all over the gland. But again, the same sort of problem exists. What if the tumor is in between those little 3 millimeter holes? So this is what it looks like to have a saturation biopsy performed, and I want to acknowledge my dear friend and colleague, professor of surgery, urologist at Duke University, Dr. Thomas Polasic, for letting me borrow his slides. So kudos to him. So this is what the setup looks like. Now, you can see in this image there's a reflection on the monitor of the gloved hands of the clinician performing the biopsy. You see them holding the probe is at the patient's rectum, and the perineal plate with all the holes in it is up against his crotch. Now the black and white image, if you look at the left side, there's a black blob there. That's urine, that's the urinary bladder, and the white band around it is the inferior or bottom wall of the bladder. And then underneath that, there's an egg-shaped gray blob, that's the prostate gland. And the white line coming off the right side of the monitor is the biopsy needle. So the biopsy needle is going through the plate, through the crotch, into the gland, going after what? We don't know. And my degree is in imaging science, and I can't see anything worth going after because everything is gray. That's the problem with ultrasound. So this is what it looks like for the patient. You get kind of an ABC, 1, 2, 3, I sunk your battleship. I'm sorry, this is not G-rated. And then you end up with this. So all the cores that come out from that saturation biopsy end up going into cups and going on to a pathologist for histologic evaluation and Gleason grading. So every core gets sliced, stained, put on a slide, labeled, and then the pathologist puts it under a microscope, and she or he will give it a diagnosis. So I like this little cartoon. Good news, the exploratory surgery turned up negative. Sometimes that's the case here, where we do all this and it all turns up negative because of what I told you earlier. The tumor could be in between the holes. So how do we get around this? Early in the 2000s, a site in Germany did the very first MRI-targeted biopsies inside the MRI scanner. And it works really well because you're able to see much better than ultrasound. So ultrasound is on the left, MRI is on the right. What do you want guiding your biopsy? For me, if it's my husband or my brother or my dad, I want it to be the image on the right because we have something to aim at. So the National Comprehensive Cancer Network has guidelines, and as recently as 2009, the guideline essentially was repeat PSA, repeat DRE, repeat random systematic trust biopsy. And I want to apologize to any urologists out in the audience. This is not a diss on anybody, it's just the technology didn't exist back then. But now we have great ways to image the gland and to use those images for biopsy guidance. So fast forward to 2012, finally multiparametric MRI is mentioned in the NCCN guidelines. European Society for Urogenital Radiology had similar guidelines talking about MRI before biopsy in 2012. That's when the American College of Radiology jumped on board and said, we'll do some standardization of imaging parameters to reduce variability, and we'll develop a lexicon and language and scoring so everyone's talking the same language. So when we look at an MRI image, these images are different sequences that we run, and they're representative of slices like a loaf of bread through the man's pelvis. Okay, so we're literally slicing him from top to bottom, and these images show an area with a cursor over it that looks to be suspicious on those three sequences as well as this sequence. And we also measure the flow of MRI contrast through tumors, which is what the curve on the right is all about. So we're able to measure different things and quantify things. We have special software that we use that allows us to put color overlays on things that are suspicious. We can segment the gland out of the pelvis and calculate things like gland volume. There are a lot of pieces of information that we can glean using special software that gives the radiologist, the urologist, and the patient more and better information about what we're looking at. So I want to talk to you briefly about PSA density. PSA density is known to be better than PSA by itself as a predictive and prognostic tool. So all it is the gland volume divided into the PSA, and it can be a very helpful predictor. Fast forward again to the year 2016, we finally see language that reads multiparametric MRI. I can't read it, hang on. Oh, multiparametric MRI followed by lesion targeting may maximize the detection of higher grade cancer and may limit the detection of lower risk disease. This is like, I'm not even a rocket scientist, and it makes sense to me that if you take a picture of the prostate and then you take a sample of things that look scary, you're gonna have a higher yield of high grade disease and a lower yield of things that don't matter. So no more poke and hope. And October 25th, 2019, the American Urological Association updated their policy statement and currently recommend MRI prior to biopsy. So that is a huge step in the right direction for the benefit of men. I mean, I can't imagine if I'm a woman and I walk into my doctor's office and he says, or she says, Bernadette, I really think from your testing, your blood tests, you may have breast cancer. So what I'm gonna do is randomly take 50, 60 cores out of your breast, and we'll see what we find. If it comes up negative, we'll just repeat it again in 6 months. That's lunacy. So the prostate is the last solid organ in the body that gets biopsied blindly. So finally, we have policy statements and awareness among medical professionals that agree imaging is going to help. So my colleagues in the Netherlands did a study back in 2006 showing the accuracy of MRI for what we call negative predictive value. That's when the test says you don't have a disease, you actually don't have it. And they came up with 91%, which is really good. Then 10 years later, in 2016, the team at Yale did a similar study, and they ended up at 96%. So in capable hands, MRI has the added benefit to be able to increase negative predictive value. So when your MRI says you don't have it, you probably don't have it, which is good. And then there's something called apparent diffusion coefficient value, ADC. And we're going to talk a little bit about how ADC relates to aggressiveness of cancer. Before I get to that though, I don't want people to be confused about MRI physics. A lot of times you'll be told, oh, you have to go to a 3T magnet, like some misconception that 1.5T is a bad thing. So T stands for Tesla, and that's a measure of magnetic field strength. So just because something is stronger doesn't necessarily mean it's better. I mean, I could drive my little Nissan from my home to work, or I could drive a Porsche from my home to work. Do I eventually get to work? Yeah, I do. But it really didn't matter. Could the Porsche get me there faster? Maybe, but not days faster, seconds faster. So that's what we're talking about with magnetic field strength. The things that matter way more than magnetic field strength are who's pushing the buttons, who's the operator. Are they credentialed? Are they experienced? What's the software on the magnet? Is it an old magnet? Is it a new magnet? Even if it's an old magnet, has it been upgraded? Has the software been updated? And then there's something we use called a coil. It's what wraps around the body part and acts like an antenna to create the picture. The coil is really important. The other thing is patient prep. If you eat a bean burrito and then go in for a prostate MRI, you might as well not go because the images won't come out well because you're digesting a burrito and it's going to interfere with bowel gas and create motion and blurring and all sorts of problems. So you got to make sure you don't eat anything for 8 hours before your prostate MRI. And some practitioners will even inject a hormone to kind of slow things down to slow peristalsis and digestion. The last thing that's more important than field strength is the interpreter, the radiologist that's looking at the pictures and telling you what's going on. If they're inexperienced, you might as well never have had the study. So make sure that wherever you decide to go, you go someplace where there's an experienced radiologist who understands the American College of Radiology guidelines and can produce a report that'll be helpful to you. So I wanted to just show you an example of 1.5 Tesla versus 3 Tesla. Left is 1.5 Tesla, the right is 3 Tesla. I would certainly pick the one on the left if it was me. Again, here's another example, 1.5 T on the left, 3 T on the right. And you have to look a little bit closely, but there are these ringing artifacts, these bands, these kind of smeary things going through the image on the 3T image. So anything that's bad at 1.5 T is going to be pronounced and worse at 3T. So if anybody tells you you must go to a 3T site, you don't need to. You really don't need to. So getting back to apparent diffusion coefficient, we're able to use a special technique to look at the image to quantify this number, this apparent diffusion coefficient, and the bottom line is the lower the ADC, the more aggressive the cancer. So this is a thing that we measure every time we do MRI, and it gets dictated in the report. So we have almost a little window into the future. The radiologist can say, you know, this is an ADC value of 660 and really should be biopsied as it could represent aggressive disease. So when we do the biopsy, you can see, if you look closely, there's a green cursor on each image. That's the abnormality that we don't know what it is. We're going to aim at that thing, and you can see it here on another sequence. Now when we aim at it, notice on the image on the left, the ADC is 691. On the image on the right, if we move that cursor just a couple voxels, we don't move it even that much. Now the ADC is well over 1,000. So we don't want the needle for biopsy to go there. We want it to go through the part where the ADC is in the 600s, not over 1,000. That tissue will be meaningless. So we take great pains to make sure that the biopsy needle falls where it belongs. The problem with historic biopsy strategies is just that you miss. I mean, the depth of the lesion could be a problem. there's only a 1.7 centimeter throw to the biopsy gun itself. So if there's something beyond 1.7 centimeters, you can biopsy that every year for 10 years and it'll come up negative because you're gonna miss. But when you do MRI, you can see the thing, you could advance the needle into it and get a piece of tissue that will render a proper diagnosis. So if you look at the pictures on the left, you see an example of totally missing the lesion. That's one problem. Then you see an example of picking up something inconsequential when something really bad is going on elsewhere. And then in the bottom image you see skimming something aggressive and missing the worst part of it. So this has historically been a problem. So my colleagues at Radboud in the Netherlands did a study back in 2010 comparing 10-core biopsy to MR target biopsy, and you don't even need like a p-value to show that it outperforms systematic biopsy by doubling the detection of Gleason 7 cancer or greater. So this is really important. You know, for Gleason 6, they perform about the same, which is fine because nobody's going to really do much with Gleason 6 anyway. Typically, they just observe it, especially if MRI has been done. But with Gleason 7, you've got to do something. Those aren't things you want to sit on unless you're in a clinical trial specifically for active surveillance of Gleason 7. So here are a couple of papers that we've published over the years talking about the benefits of MRI prior to biopsy and the benefits of MR target biopsy. So what does it look like for the patient? I talked earlier about coils. That tan thing on the patient's bottom, that's a coil. So it's got two pieces. One part's on his front and one part's on his back. We have a little needle guide, smaller than my index finger, that goes in his rectum, and then it mounts onto that white and blue plastic thing that allows us to angle in any direction to get to the thing that's hard to get at. So it's a little bit like a video game. We've got a software program that we use that allows us to aim at the thing that we're interested in. And we can adjust the knobs and the levers on that device to get a trajectory that goes right through the most concerning part of the tumor. So we take 2-3 samples, send them off to the pathologist, and call it a day. And so there's a picture of one of our urologist colleagues doing a biopsy inside the MRI scanner. And when the tissue comes out, if you look at the middle image, it looks like a little piece of linguine. I mean, it's a little small caliber thing, about 1.8, 2 centimeters long. That thing gets sent to the laboratory, sliced, stained, put on slides, and you get what's called a photomicrograph, which is that little thing in the lower right corner. Our pathology lab has done a beautiful job of customizing our reports for us. They put in big bold letters in red writing what's the worst thing that we're looking at. They build a chart that shows how much is involved, what the Gleason score is. Then they put a picture of the biopsy needle inside the tumor. That's very important. They put a JPEG image next to the photomicrograph. So literally, in a court of law, it's indisputable where that tissue came from. So into now, it's essentially a scale of 1 to 5, where we identify the dominant cell pattern in that specimen, and that's the primary Gleason grade. And then we look at the second most dominant cell pattern in the specimen, and that's a secondary grade, the sum of which is the score. So if you take an example where the dominant cell pattern is 3, and then the secondary pattern is 4, that's a 3 plus 4 equals 7. Now, another example would be the dominant cell pattern being 4 and the secondary pattern being 3. That is also a 7, but in the second example, that patient has a worse prognosis because the 4 architecture is more aggressive in that case. So cell architecture is what determines prognosis. I like to give all my patients access to the National Comprehensive Cancer Network guidelines for traditional prostate cancer treatment. Every man should know what his options are. No one should be forced down a certain path. Surgery, radiation, different forms of radiation, cryotherapy, HIFU, RF, electroporation, lots of things out there. Laser, in my opinion, has been the thing that I chose to pursue. Years ago, I made a little matrix and I compared all energy sources and looked at the benefits and drawbacks of each. And the thing that came out on top every time was laser. And it's because of its precision and its controllability. They had been using it in the brains of children for intractable epilepsy. So they would drill a little hole in the child's skull and under MRI guidance, insert the laser fiber and put it in the temporal lobe and burn it. And watch the burning on MRI using real-time thermometry. So my thought was, if it's safe enough to stick in the brain of a child, I can pop it in the prostate. So that's how this all was born. So I'm currently undertaking a phase 2 clinical trial, investigating the use of laser interstitial thermal therapy delivered transrectally under MR guidance using real-time MRI thermometry in an outpatient setting. So the patient walks in and walks out. We burn the cancer and follow them for 20 years. The very same process that we use for the biopsy, we use for the laser. It's a little device the size of my index finger, and that's actually my index finger there. You see it's even smaller than my index finger, and I'm a little person. It's a small thing. So then we insert either a cooled or non-cooled laser fiber with a heat diffusing tip. And then we watch what we're doing on a visualization platform that allows us to see what we're cooking, how long we cook it, and what damage we do. And all this stuff is FDA cleared, but we're using in an environment where it's not indicated for prostate cancer use. It's indicated for soft tissue necrotization, which is why it's a clinical trial, not clinically available today mainstream. So that's the little laser box. That stays outside the room, and we put a long laser fiber, about 30 feet long, onto that, and we put it in the room, and that's how we get the pictures of the heat being dispersed into the tissue. So that rainbow color picture there is a thermal map, and the yellow overlay on the bottom right image, that's irreversible damage estimate. So we're able to watch what we're cooking as we cook it, and we have documentation of every voxel that achieved a temperature over 60 degrees Celsius, which means it experienced instantaneous cell death. So in a matter of 2 minutes, we're able to contour to what we want to destroy and destroy it. So the red cursors there and the green circle, that's around the tumor. The blue cursors are protecting things that are important. So if the temperature exceeds a certain threshold, the laser shuts right off. So we don't damage things that control continence. Our patients don't have to wear diapers. They don't suffer erectile dysfunction or impotence. So with a less than 1% infection rate, less than 1% incontinence rate, and less than 1% impotence rate, I think it's a really good first-line treatment for certain men. So here's an example of the thermometry, the pretty rainbow image just showing where the fiber is and where the tip of it is. Here's the irreversible damage estimate showing what we killed. And then here's some real images of a patient. This man had Gleason 3+4 disease. We documented it well with his preoperative MRI. After he had his laser, now you see it, now you don't. There was the tumor. There it isn't. There's a black hole there now where the tumor used to be. And notice, there's nothing anywhere near his rectal wall, nothing near his urethra, nothing near any of the nerves that control erection. So he's living happily ever after. This is a side view of that same treatment. You can see a nice tall black hole where the tumor used to be. And we always biopsy our patients. We don't just treat them and walk away. At 6 months postoperatively, every patient comes back for a biopsy, because even if we don't see anything there, we'll put a needle in the treatment site just to prove that we achieved cancer control. It's very important. You can't just have the treatment and walk away. You've got to follow it. So his negative biopsy was our assurance that we did a good job. Now, why laser? When you look at other energy sources, you have a very, very thick transition between treated and untreated tissue. You see it with HIFU, you see it with RF and cryo, but with laser, look at that transition zone. It's only 1 millimeter. That's why we're able to get so close to important structures without damaging them, because the transition zone is so thin. we're able to spare viable tissue very successfully. So as of last quarter, we had done around 161 patients, and the PSA results are impressive. In our entire patient population, the PSA dropped something around 37%, so that's a good thing. Their sexual health scores also stay stable. Their urologic function scores also stay stable. But in addition to measuring functional outcomes, I wanted to know, how are my patients doing emotionally? How are they feeling? So in the whole population, everybody is stable. In the second chart there in the middle, that's the patients that had never been treated for the prostate cancer ever, and their first treatment was the laser. They stayed pretty stable throughout the first year. When you look at the right chart, the salvage chart, these are men that had radiation therapy, they had prostatectomy, they had brachytherapy, they had, you name it, they had something and their cancer came back. So they present initially, you know, pretty optimistic, but you know, they're anxious, they want a cure, and then their emotional distress scores go down at 3 months. But then wait, the 6-month biopsy is coming up, they get a little bit anxious again, and then when the biopsy comes back negative, at 12 months, their distress score goes way down again. So I feel like we're doing a service to these people, not only in achieving functional outcomes and oncologic control, but we're also helping their hearts and their heads. Because really, who wants to be bothered by the daily black cloud of the C word, you know? So these fancy Kaplan-Meier curves are just showing you that in our population, we have had only one case of metastatic disease, where after we treated the patient, the cancer went either to the lymph nodes or to the bones. Only one out of nearly 200. And at 10 years, we have had 0 men die of prostate cancer. So don't be mistaken, some men have died, but it's of things like skin cancer, so look after your skin, Parkinson's, esophageal cancer, and one other man died of a cancer that we didn't know what it was, but it went to his brain and unfortunately his lungs. Prostate cancer doesn't like to do that. Prostate cancer likes to go to the lymph nodes and the bones. So in our entire population, there's been 0 prostate cancer specific mortality. So in summary, it's very safe, very precise, it's an outpatient thing. We sculpt the therapy. Our transition zone is super thin. We do 2 planes of imaging and observation, watching what's happening with safety boundaries over things that we don't want to injure. And it's very amenable to treating cancers way down in the bottom of the prostate, called the apex, where it's like a little tight corner that you gotta get into, and we access it without a problem. And also cancers in very large prostates that would be impossible to reach with any other technique. So the one thing that I get worried about is our whack-a-mole patients, where after we treat them, their cancer comes back and then they've got 3 or 4 more brand new cancers someplace new. Those men we like to consult with a urologist or an oncologist. The last thing I'm going to talk about is genomic testing. So when we do the biopsy, you remember I showed you the laboratory report shows the needle taking the sample. It shows the photomicrograph, which we get the Gleason score from, but we also do a test called Decipher. This test is a genomic test that gives an evaluation of 22 well-known genes in prostate cancer and will render a low, intermediate, or high-risk score for the patient. It used to be used after prostatectomy to determine, does this patient need radiation on top of their surgery? We use it to tell our focal therapy patients what their future might look like from their biopsy specimens. So we also run a test that includes the entire human exome, which is 1.4 million genes, and that's a research project that I've been working on now for about 5 years. So the report on the left shows you the blue is low risk. You can see that little bar there. The gold is intermediate risk, and the red is high risk. So when I've got patients that are high risk, they're consented and consulted a lot differently than the guys that are blue. The guys that are blue, low risk, I don't lose sleep at night. But the guys that are red, I think about them a lot. The gold, if you're at the low end of the gold bar, I'm not so worried. If you're at the high end of the gold bar, we need to talk and follow closely. So in conclusion, I want to acknowledge that I'm also a member of the International Laser Network, which is currently being absorbed by the Focal Therapy Society. Our president is Professor Jürgen Futterer. Our secretary is Sangeet Gai. Our treasurer is Itek Otto out of Chicago. And I could never have done any of this work without the support of the team at HALO Diagnostics, formerly Desert Medical Imaging, which I always slip up and say. Dr. John Feller is our medical director. You see the group of 4 people there. The guy on the left is Wes Jones, our MRI tech extraordinaire. The tall gentleman with the mustache is Axel Winkle from In Vivo, a subsidiary of Philips Healthcare, who helped me in my development of this surgical technique and devised many of the instruments that we use day-to-day in clinical practice. The lady in the white jacket is me, and the man to my left is Dr. Stuart May, who I acknowledge posthumously for his dedication, devotion, and passion for our prostate cancer patients. The handsome young man in the picture on the right there is Dr. Roger McNichols, my friend, colleague, and mentor, who worked with me originally on the preclinical testing, and I acknowledge him posthumously as well. And the lower right photograph is our biostatistician, Dr. Rob Toth from Rutgers University. So all of these people contributed immensely to this work and made this possible. So here's to the end of Poke and Hope. If you have questions, if you have comments, we have a live Q&A right now. I'm happy to talk to you. If you're a little afraid to send your questions or want to email me directly, it's Bernadette@halodx.com. I understand that this program will be airing multiple times in the coming months. And again, if you've got questions, no matter where you are, I'm happy to answer you. And if you're around on September 19th, I wanted to acknowledge Zero Cancer, an organization that's fighting for the end of prostate cancer. They were unable to hold their 5-kilometer run this year because of COVID, but they're holding it virtually on September 19th, which is a Saturday. If you're interested in participating or donating, I'm going to be running it virtually, so if you want to send me some cash, I'm happy to accept it on behalf of Zero. Look into details at www.zerocancerrun/Coachella. I hope I got that right. www.zerocancerrun/Coachella. And again, if you want to send me cash, send it to 74785 Highway 111, Suite 101, Indian Wells, California, 92210. Make your check payable to Zero Cancer, and I'll run my tail off for you.
All right, we have Rich asking, are you taking new patients for your study?
Rich, that's an excellent question. So when I originally did the sample size calculation, it came out to 998, so I rounded it up to 1,000. If I stuck with that number, I would be 95 by the time we saw our 1,000th patient in 20-year follow-up. I'd probably be dead, or I'd be 95. So seeing as our numbers have stayed very stable for about 3 to 4 years, I rang up our institutional review board and I rang up our biostatistician and I said, since our numbers have stayed so stable for so long, do you think it's safe to reduce the number of accrued patients to 200 instead of 1,000? And I know this is a long answer, but I gotta give you the backstory. And everybody said yes. Go ahead and stop accruing at 200, then go commercial. So that's what we're gonna do. I'm at patient, I think yesterday I did patient number 187, and when I get to patient number 200, we will stop accruing for the study, so you won't be able to have your data entered into the repository that will contribute to the body of evidence for justification of why we do this, but you can still get the procedure done commercially. No big deal. And that being said, those 200 men who are in the study, we are continuing to watch them for 20 years, and if you come to us commercially, we're going to watch you exactly the way we watch our research patients. So the only difference is your data won't be put in the bucket with theirs. And so everybody knows there's 3 limbs to this study. I showed you the treatment naive limb, those guys that have never had anything ever before, and I showed you the salvage limb, which is the guys who have had radiation brachy, whatever, kitchen sink. We also have an HIV positive limb. There's certain men who won't do well in the surgical suite. We just know it. Guys with coagulopathy, guys with spinal cord injuries. We have one patient who's a quadriplegic. These men benefit greatly from, coming into our facility, being seen on an outpatient basis, having their procedure, and going home. There's no general anesthesia, no overnight hospital stays. It's in and out, and I mean, it sounds like a breeze. I mean, it's a surgical procedure, and I liken it sometimes to childbirth. The better shape you're in when you have your baby, the quicker you'll recover, as a general rule. So the better shape you're in when you come see us, the more quickly you'll recover, and the better your recovery will be. So I know that was a long answer. I hope I answered it. Any other questions?
All right, next question here is, what is your perspective on the PCA3 as an alternative or adjunct to PSA and pre-MRI?
That's another great question. So we got PCA3, we got 4K, we got this, we got that, we got urine tests, all this stuff. Earlier I mentioned PSA density is what we hang our hats on. It's such an accurate predictor of bad outcomes. I don't look at those other tests so much in a research setting. Clinically, we don't look at them. If we get them, we look at them and go, oh, okay, what's this PSA density? So that's how we use it. Other people may feel very strongly about it. I was actually an investor in a certain company, and I dumped the shares because it wasn't doing what I thought it would do. And we can't always be convinced that the newest thing is the best thing. We've got to see runtime, and we've got to compare it to clinical outcomes. That's how I decide with Dr. Feller, what is HALO going to run with? We test it in the Innovation Center first. If we see good clinical outcomes and they correlate to the test results, then we release it enterprise-wide. But if we see something that doesn't pass the sniff test, we're like, no. So anyway, we don't use it clinically. If patients come to us with it, we'll look at it, but it doesn't trump PSA density.
All right, thank you. If the laser RX is clinical trial only at this point, how would one access it?
You would go to www.clinicaltrials.gov and look at the inclusion criteria. There is a cost. I did not get a big fat R01 grant from the NIH, so nobody dumped $3 million in my lap to do it for free. So unfortunately, the treatment, the follow-up for 1 year, and all that is $24,900. So I know it's a hefty price tag, but it's cheaper than other things, and we gotta look at things like quality of life. When we go commercial, it's likely the price will stay the same. I'm not a money person, I'm not a bean counter, and I don't set price. So I think it's important though that everyone understand that this is patient-funded research. If the DOD or the VA or NIH would write a grant or would represent this through a grant submission, I take it, believe me. I had a patient 5 years ago give me a check for $250,000 after I did his consultation, and he said it's to finish my research. And so for a nanosecond, I thought about putting it in the Bernadette Greenwood College Fund, but I didn't. What we did was I spoke to Dr. Feller and Dr. May about it, and we decided that we would form a foundation, because not every man has the funds to afford a $25,000 treatment. So what we did was we pushed the money away from ourselves so there was no conflict of interest, and the Focal Therapy Foundation exists now to help men fund their treatment.
That is amazing. And what is the status of insurance reimbursement on this, just to
None.
confirm?
So, and the reason why is because if this were pancreatic cancer that we were dealing with, and I had 10-year results, CMS would be all over it. Centers for Medicare Services, they'd be all over it. But because prostate cancer is such a slow-growing indolent disease, they want to see where you sit at 20 years. Are you non-inferior to standard of care treatments? Are you better? What are the side effects? What's the morbidity? Things like that. That's what they're assessing. That's why we did a 20-year observational study. So every year, even though we're not yet to 20 years, every single year we present at the Radiological Society of North America, the American Urological Association meeting, and the American Society for Clinical Oncology, and a handful of others. but the big meetings, the big medical meetings, they see us every year, twice a year, and even at little local meetings. We go, we're transparent, we show our results. And I told you, we have a biostatistician. I don't crunch my own numbers. I have a database and a data manager. She de-identifies the data and sends it to the biostatistician, and he runs quarterly reports for me. So it's not like Bernadette Greenwood getting up at the podium saying, oh, look how good we're doing. It's an outsider running our numbers, giving me a report by which I can then say, this is where we sit compared to traditional treatments. So I think the longer we go at this and the more we publish and present, it may get some attention. And I hope there's somebody at CMS watching right now, or Blue Cross Blue Shield, Aetna, Cigna. Believe me, you're gonna save a bunch of bucks. So rather than having these men on Viagra and catheters and diapers and penile implants and all the horrible things that go along with traditional treatments, and don't get mad at me, urologists and radiation oncologists, don't get mad at me, but we can really do a lot if this is a first-line treatment. Everything else stays on the table. There's no compromise to surgical dissection, post-laser in prostatectomy, and radiation's always on the table. So you've always got more stuff to consider. And the great thing about medicine is as things evolve, we're experimenting with immunotherapy, oncolytic viruses, checkpoint inhibitors. You know, one of these days it may become laser plus. So we'll do laser and we'll drop something else in there at the treatment site to decrease our recurrence rates even further from 17 to 21%. I'd like to see it get down to like 5 to 7%. That would be a dream come true. And hopefully it'll happen in my lifetime. We're working hard at it.
And how would they get a hold of you to schedule a consult?
I'm going to give you a phone number, 760-776-8989. And you're going to want to dial extension 123, and that's a gentleman named Dennis Lacey. He is our concierge prostate coordinator. He was a registered nurse with a urology background, so he's really good to talk to. And then the other person you could call is extension 121. That is my close associate research coordinator and data manager, Mari Mitchell. Either one of those two people can take your call. Not a good idea to call the main office number because the research team is highly trained in how to respond to your questions and how to handle what you want logistically. I'm the person clinically that you'll ultimately be connected with our urologist, Dr. Jeffrey Hers. Dr. Feller and I and Dr. Hers perform the procedure with our technologist and a nurse. So we will always get on the phone with you preoperatively to do the consult. And I believe, if I remember, it's a $250 consult fee. So they'll collect that from you at the time of scheduling. And that comes off of your treatment fee. If you end up going with us for the laser, the $250 comes off. And for those of you in the South, I taught like 3 doctors in the world how to do this, and a bunch of folks kind of learned how to do it. And right now there's around 11 places in the world doing some form of it. I'm biased, I'm so biased, forgive me. If you were my brother, my husband, or my dad, I wouldn't want anybody but Dr. John Feller putting his hands on you. That's just because he's the best in the world, and that's just a fact. Second best is a guy named Dr. Eric Karaminian, who's been at this now for about, I think, 5 years, and he is in Houston, Texas, and he recently joined HALO, formerly Prostate Laser Centers. So if you're in the Texas area and you want to go to Houston, please do. Give their office a jingle. I don't have their number off the top of my head, but if you Google Prostate Laser Center, you'll find Dr. Karaminian's office. We're in Indian Wells, California, and he's in Houston, Texas.
All right, that concludes our Q&A session and concludes our wonderful informational session today. Thank you to the team of HALO Diagnostics for joining us today. And a shout out to our member extraordinaire, Ms. Lauren Del Sardo from Desert Health,
Love you,
the
Lauren.
Valley's leading resource for health and wellness here in the Valley. So thank you, ladies and gentlemen. This broadcast will be taped and you can find it under the broadcast section of MTL. Scroll on down to the Polo Club and you can watch it at any point that you may find it necessary. Please pass the word on to our other members, as this is definitely information that could be very useful down the road, if not right now. But thank you again for joining us today, and we hope to see you very soon with our next lifestyle session. Have a great day. Thank you, everyone.
Thank you.